then Vice Chairman of Physiology 2013, then Sona Master in 2015 and 2019, and faculty in Swasam, then faculty in Engineering, and secretary in Engineering 2022, faculty in Preeti Anaesthesia update, delivered his lecture in ISEC on Tamil Nadu and ISEC on Puducherry. So really I feel he is that person to give this lecture. So now I request Dr. Ganesan to start.
Welcome to this orientation course, the first of its kind in the nation. And respected chairpersons, respected ISA dignitaries, State Secretary Srinivasan, President Department sir, and respected members of ISA Kanyakumari for the special invite. And a special thanks to Professor Edward Johnson sir for giving us this opportunity to present in this August gathering. First of all, going away straight to the topic, we are going to discuss about the applied anatomy and physiology of the neuraxial blocking. To have a successful and problem-free spinal anesthesia, you have to be very sure about the anatomy and the physiological changes produced by the local anesthetic in the subarachnoid block. You have to be very clear what's going on there, how to go in very successfully, because this is the most common anesthesia practice everywhere in the world. Coming to the history, James Leonard Collins was a neurologist. James Leonard Collins was a neurologist. He was the first person who had given a spinal anesthesia accidentally. He gave cocaine. He injected cocaine into intrathecal space and produced weakness in the hindquarters of the dog. Next time when he wanted to reproduce the same in human beings, he couldn't do it because next time he injected into the epidural space. First time he didn't witness the CSF flowing out. So he gave unintentionally into the intrathecal space. He only coined the term spinal anesthesia, and later on lumbar puncture was invented by Heinrich Wicke. He only witnessed CSF flow, and later August Bayer, who is considered the father of spinal anesthesia, was the first person to use this cocaine injected intrathecally for surgery in humans. Coming to the vertebral column, it has got three curves. Convex anteriorly in the cervical region, and convex anteriorly in the lumbar region, and convex posteriorly in the thoracic region. This contributes to the kyphosis, thoracic kyphosis. This contributes to the lumbar lordosis existing in the spine. We have got three prominent landmarks, namely the spinal process, which is at the C7, and then the inferior angle of the scapula, and the rib margin which corresponds to L1. L1 is an important landmark because this is the place where the spinal cord ends in adults. Normally, what we palpate before giving the spinal is the Tophius line. It is the line joining the superior aspect of the iliac crest. It corresponds to the L4, L5 vertebra. Without injuring the spinal cord. This is the Tophius line. This is the area where the spinal cord ends, and this is going to be a safe area for giving the spinal anesthesia. Coming to the anatomy of the lumbar spine, the vertebra is there. It is arranged from top to bottom. Lower down you will see the sacrum fused as a single bone, the sacroiliac joint. This is a single lumbar vertebra. This is anterior, this is posterior. This is supposed to be the spine where you palpate at the back, and this is a vertebral body. The vertebral body takes out the weight of the body, and this is supposed to be called the neural arch. This is a spinal canal which hoses the spinal cord safely without getting injured from the other structures in the body. If you have sustained a trauma, this spinal canal hoses the spinal cord without causing much trauma to the spinal cord. Next slide. And this is another, next. This is another view of the vertebral column. The soft is a jelly-like material, the outer is a fibrous structure. It acts as a shock absorber and facilitates all movement of the vertebral column.
Next slide. This is a single isolated lumbar vertebra. What you see is the vertebral body as we have discussed above. Next slide. Next you have the spinous process here. This is what you palpate at the back. Next slide. Then you have the transverse process on either side. Two transverse process and one spinous process. Next. Next you have an area where the vertebral body gets connected with the transverse process. This is called the pedicle. This is the area where the pedicle screws are applied in spinal surgeries for stabilization of the spine. This is the pedicle. Next slide. And this is an important area called the This is an important area called the lamina. It connects the spinous process with the transverse process. It is the interlaminar space where you approach for the intrathecal injection. And this articulation, next. This articulation is called the facet joint. See, the superior articular process articulates with the inferior articular process of the subsequent vertebrae. Next slide. Coming to the vertebral body again. Next. The vertebrae are arranged sequentially and the spinal canal is there inside. It hosts the spinal cord. The spinal cord ends at L1 for an adult, below which the nerves hang freely. This is called the cauda equina, like a horse tail. The spinal cord ends here, but the nerves hang freely. Even though the nerves hang freely, each nerve exits at the subsequent intervertebral foramina. Next. This is a typical upper thoracic vertebra T1. This is a lower thoracic vertebra T10. This is a lumbar vertebra L5. See the angulation of the spinous process. This is so oblique. So when you approach for a thoracic epidural, you have to go so oblique to reach the epidural space. Likewise, when you approach for the lumbar, you need not so go oblique. You can go straight. You need to angulate when you don't get the intrathecal space. Next slide. This is the same vertebra of the lumbar arranged in extension and ligamentum flavum during spinal anesthesia. After piercing the ligamentum flavum, you enter into the epidural space, and then you have the dura and arachnoid as a single layer. When you pierce the dura, you enter into the intrathecal space. Therefore, you have the supraspinous ligament, interspinous ligament, ligamentum flavum. Before approaching into the spinal canal, first you have the epidural space. When you pierce the dura, you have the intrathecal space. You have the anterior and posterior longitudinal ligaments respectively on the anterior of the vertebral body and the posterior of the vertebral body. This is posterior, this is anterior. You approach like this. Next slide. These are the structures pierced by the spinal needle in the midline. Normally you give spinal in the midline. Only when you encounter much difficulty, you have a bony interference, you go for the paramedian technique. These are the structures you encounter in the midline. These are the structures you encounter in the paramedian technique. In the paramedian technique, you omit the supraspinous and the interspinous ligament. You go through the paraspinous muscle and encounter the dura and give the spinal anesthesia there. Next slide. And regarding the innervation along the vertebral column, the facet joint is well innervated. Only when the needle pokes the facet joint, you have severe pain. But the supraspinous, interspinous and other ligaments are partially innervated. Therefore, when you give spinal anesthesia, the most painful structure is the skin. You have to infiltrate the skin and you have to go a little bit deep to infiltrate the supraspinous and interspinous ligament. The ligamentum flavum and the posterior dura, lamina and the vertebral body are pain insensitive relatively. Next slide. These are the arrangement of the spinal nerves, how they exit through from the spinal cord. You see, you have 7 cervical vertebrae but 8 cervical spinal segments. Therefore, for the first C1 to C7, they emerge above the corresponding cervical vertebrae. Next. For C8, they emerge between C7 and T1 vertebra. For the remaining from T2 to S4, they emerge below the subsequent vertebrae, respective vertebrae. Therefore, for C8 only, they emerges between C7 and T1. For C1 to C7, they emerge above the cervical vertebra. From T2, they emerge below the respective vertebrae. Next. This is a section of the vertebral column and the spinal cord. You see the spinal cord ends at L1. This is L1, spinal cord ends at L1. That is called the conus medullaris. The end point of the spinal cord is called the conus medullaris, below which the nerves for L2, L3, L4, L5, S1, S2, S3, they hang freely like a horse tail, ponytail. So it is called the cauda equina. Even though they hang freely, they exit through their respective vertebrae. Okay. Next slide. And the spinal cord is protected from outside by the vertebral column, but the spinal cord needs to get protected from the vertebral column because it can go and touch the vertebral column every time it moves. So it has three coverings called the meninges as in the brain. Therefore they cover the spinal cord, they give a protective layer to the spinal cord, they host the CSF, cerebrospinal fluid, and provide nutrition to the spinal cord. This is the innermost layer called the pia mater. This is called the tender mother, and the middle layer is called the arachnoid mater because it has got a spider-like appearance. And the outermost, the innermost is the pia mater. It is called the tender mother. It is adherent with the spinal cord. The pia mater is adherent with the spinal cord. Next comes the arachnoid mater. It is like a spider web. You see, it contains the cerebrospinal fluid. It is like a spider web. Next comes the dura mater. Dura mater is otherwise called the tough mother. It is so tough and it provides some resistance. You have to pierce the dura before entering into the intrathecal space. Coming to the meninges, dura. The dura is the outermost covering. It fuses with the skull at the foramen magnum, below which it ends at the S2. The spinal cord, next slide. The spinal cord ends at L1, but the dura mater continues and ends at S2. Therefore, the subarachnoid space ends at S2. The CSF will be there till S2. And the dura is a tough layer and it has got many clefts which allow for the dural permeability. When you inject into the epidural space, the drug, the local anesthetic can diffuse through the dura and enter into the subarachnoid space. And the dura has got longitudinal and circumferential fibers. Predominantly, the fibers are arranged in the longitudinal fashion in the dura. So, when you give a spinal, the bevel of the needle, the Quincke needle should be faced along the bevel of the spinal needle should be faced along the long surface of the longitudinal fibers so that the needle will separate the dural fibers rather than tear the dural fibers. So, when in sitting position, the bevel should be faced laterally. In the lying position, the bevel should be faced in the superior or the inferior to the roof surface, so that the needle will separate the dural fibers rather than cut the dural fibers. This is a pencil point needle. This is a Quincke needle, what you use routinely. This is how a dura is torn by a 25 gauge Quincke needle. And this is how a dura is damaged by a 27 gauge pencil point needle. The dural tear caused by the Quincke needle is more to cause CSF leak and subsequently post-dural puncture headache. And these are the other two layers, namely the arachnoid and pia. They are discussed together because they have a common microscopic origin and an embryological origin. You see, the dura is closely adherent to the arachnoid mater. The pia mater is closely adherent to the spinal cord. You have a space there. This is called the intrathecal space through which the CSF flows. You see, the spinal cord ends at L1, but the dural sac ends at S2. But the pia mater which is closely adherent to the dura continues here till S2, which is called the phylum terminal. The pia mater continuously extends and attaches to S2, which is called the phylum terminal internum, and beyond which it continues there and goes and attaches to the coccyx, which is called the phylum terminal externum. Therefore, you need to have four structures to be prominent. The end point of the spinal cord is called the conus medullaris. The subarachnoid space continues till the S2 and the dura ends at S2, and the pia mater continues there continuously till S2 and gets attached there. It is called phylum terminal internum, and the pia mater continues there to get attached at the coccyx. It is called the phylum terminal externum. This is how a spinal anesthetic is administered. This is the space, this is the dura, and this is the cauda equina. The nerves hanging freely in the subarachnoid space. This is how a needle enters. into the interlaminar space, pierces the dura and deposits the local anesthetic into the subarachnoid space where the cauda equina is hanging freely in the CSF and the local gets administered there. And these are three scenarios. One, this is a Whittaker needle. The needle is inside the subarachnoid space. When you aspirate, you get CSF flow. When you inject, the drug is deposited into the subarachnoid space here, and this is the cauda equina there. And another thing, when you accidentally aspirate, you get into the epidural space. So when you inject some 2 or 3 ml of spinal anesthetic, this goes into the epidural space and you have failure of spinal anesthesia. One is the rarest situation where you inject in between the layers of the dura and the drug goes inside. This is called the subdural injection. This is rarely occurring. This is not in routine. And regarding the CSF is formed in the base of the brain by the choroid plexus. The choroid plexus secrete the CSF and it gets absorbed in the arachnoid villus there. What are arachnoid villi or granulations? They are extensions of the arachnoid matter where the dura is absent. Where the dura is absent, the arachnoid protrudes out like villi. It is called arachnoid villi or granulations. These are the area where the CSF is absorbed. The CSF is produced by the choroid plexus, absorbed by the arachnoid villi. From the blood through the choroid plexus, CSF is produced. From the CSF, it goes to the arachnoid villi and finally drains into the dural venous sinuses where it gets absorbed. How does the CSF come from there? Only 50 ml of CSF is found in the distal intrathecal space. Only 50 ml is found here. How does it come? It comes like this. It comes to the posterior aspect of the cord and ascends to the anterior aspect of the cord. The circulation of the CSF is like this. Why does the circulation occur? You have these cerebral arteries there in the brain. They constantly pulsate. While they pulsate, they create some oscillations like water current established in the oceans. So these oscillations are transmitted so that the CSF is pushed from the brain slowly. They descend down and ascend up. This is what happens. This is the pulsations of the brain. This pulsation is transmitted from the brain through the CSF and this causes the CSF circulation to go as an oscillation. This oscillation is more in the cervical region, 9 mm per cycle, and less in the thoracolumbar region. This facilitates the distribution of the spinal local anesthetic when you inject into the intrathecal space. You inject the drug in the intrathecal space. Because of these oscillations going on in the subarachnoid space, this drug is uniformly distributed into the intrathecal space. And you have the CSF composition. When you have doubt while given an epidural anesthesia whether it is CSF or not, simply put a glucometer there and put the fluid there in the glucometer. It will show sugars. This sugar will be 2/3 of the plasma sugar. And coming to the action of the local anesthetic in the spinal cord, what has happened? The spinal nerves, as they exit from the spinal cord, they are devoid of the layers of the dura and the arachnoid. They don't have the dura and the arachnoid because they are from the spinal cord. So these nerves are people like without shirts. They will be exposed to more cold, they will feel more chillness. So these nerves, when exposed to local anesthetic, they have a profound block because they don't have the outer covering of the dura and the arachnoid membrane. These have smaller roots, so larger surface area, though therefore the local anesthetic penetrates very easily. Other mode of action of the local anesthetic is through diffusion to the superficial layers of the spinal cord. First action is through the spinal nerves. Second action is through the diffusion to the superficial portion of the spinal cord. The third action is through the diffusion to the Virchow-Robin space. What are Virchow-Robin space? They are spaces created into the spinal cord where the spinal arteries enter. As the spinal arteries enter into the spinal cord, they take a layer of the subarachnoid space inside so that the local anesthetic deposited in the subarachnoid space will diffuse through this space and enter into the deeper layers of the spinal cord. This is an anterior and posterior route. Anterior nerve route is concerned with the motor blockade, posterior with the sensory blockade. These are the cut sections of the spinal nerve roots. These are the lumbar and these are the sacrum. Therefore, the thickest root are the L5, S1 and S2. Other are thinner roots. So thinner roots gets blocked very easily, thicker roots take more time to get blocked. What happens when you give a spinal anesthesia? You would have observed for a cesarean section, even though the surgeon is operating in the abdomen, the patient will be able to move their ankle, because ankle root value is L5 and S1. Therefore, the L5 and S1, the thicker nerve root, takes more time to get blocked. Before it, the T10, T11 and T12 gets blocked. So easily the patient won't having pain, but still able to move their ankle. By the middle of the surgery only, they will be able to. Sometimes when you give a spinal anesthesia, you have a bloody tap. You need to know where the blood is coming from. This is the posterior part, this is the anterior part, this is the vertebral body, and this is the spinous process. That is the supraspinous ligament. When you insert the spinal needle, it comes like this. Accidentally, for beginners, they will go and hit the vertebral body. So, when you hit the vertebral body, you approach the posterior epidural space, intrathecal space, and the anterior epidural space. This is the cardia equina getting floated in the subarachnoid space. So, what happens? The blood will come from the veins from the anterior epidural space. Therefore, what you do? You withdraw the needle, you have an access to the intrathecal space. Therefore, the blood clears out and you have clear CSF flowing out. And regarding the order of blockade, we have a simple mnemonic ATP, GTP, MVP. ATP is adenosine triphosphate, GTP is guanosine triphosphate, and MVP is mitochondrial prolapse. The first nerve to get blocked is the autonomic preganglionic, named by the B fibers. Next is the temperature, followed by the pinprick, which is A delta. GTP is greater than pinprick and touch and pressure. Later on comes the motor, vibration and proprioception. This is an easy way to remember ATP, GTP and MVP. Why it is so? You have, analyze this is a spinal nerve, and see the outermost fibers will be blocked first, because the local anesthetic diffuses from the subarachnoid space to enter like this. So it blocks the outermost fibers. Next blocked fibers will be the smaller fibers. Larger fibers take more time to get blocked. Next block will be the smaller fibers. And lately blocked will be the fibers with the myelin sheath. Therefore, fibers which lack myelin sheath get easily blocked. Fibers which have more myelin sheath take more time to get blocked. Fibers in the superficial aspect get blocked easily. Fibers in the deeper aspect take more time to get blocked. So the outermost is the B fiber, which is for the autonomic. And next comes the C fiber, which carries the temperature sensation. And next comes the A delta, which carries the pinprick sensation. Next comes the A gamma. And next A beta, which is for the touch. And A alpha, which is for the motor. The motor is the largest fiber. It has got the myelin sheath. Finish in 5 minutes. Therefore, the order of blockade will be from autonomic, sensation and then motor. The reversal will be for the recovery. Because this is due to the geometric arrangement of the fibers, and you see there the preganglionic B fibers, they have got a lesser diameter. The C fibers, they have got a still more lesser diameter, and the largest diameter fibers 12 to 20 are A alpha, and they have the highest myelin sheath. And this is the reason for the differential blockade. This is the reason for the differential blockade. Where you have the pinprick sensation, the two segments above will be the autonomic and two segments below will be the motor blockade. This is how a hyperbaric solution will spread. More spread will be to the dependent portion. An isobaric solution spreads equally on both directions, and a hypobaric will be opposite to that of the hyperbaric solution. And this is a glass spinal model. Imagine this is a spinal canal, and the patient is put in the lateral position, and they inject two solutions, one isobaric on the up and one hyperbaric on the below. You see how a hyperbaric solution spreads. It predominantly takes the lower aspect because it is the dependent position, whereas isobaric spreads equally on both sides. After giving the spinal anesthesia in the lateral position, they are turning the patient to the supine position now. See, the limit of the spread is limited to the thoracic level because you have a thoracic kyphosis which doesn't allow the drug to go up. Imagine this is a spinal cord and you give total 100 molecules of bupivacaine 30 will be restricted to the lower, and only 2 will reach the upper part. After some time, you imagine there is a clearance of 2 molecules per every 10 minutes. Therefore, 28 will still remain here. The upper part, there won't be any molecules to produce anesthesia. After that, even 2 segments will be having no molecules to produce anesthesia there. This is the reason for a differential blockade, and this is the reason for having profound blockade of S2, S3, S4. Bladder sensation won't be got till even 4 hours of giving spinal. The height has got no change. Extremes of height will have increase or decrease in those. Maybe the height of less than 130 centimeters and height of more than 180 centimeters. And regarding weight, BMI plays a major role, and abdominal masses, even pregnancy, because it pushes the IVC and causes engagement of the epidural veins and decreases the CSF volume. Even 2 ml of local anesthetic can have the effect of an adult of even 4 ml of local anesthetic. Site of injection, only blocks higher than L2, L3 has got a higher spread, and increase in dose will have a higher spread and longer duration. And these are the causes for failed spinal, because sometimes you have a posterior septum posticum in the posterior aspect of spinal cord, which extends from the spinal cord to the subarachnoid membrane. This have some cyst, spinal cyst accidentally. When you aspirate, you have CSF. When you inject, there won't be any loss of sensation. This is due to the presence of cyst within the subarachnoid space. And lidocaine has got a first order absorption process. It is a short acting anesthetic. Bupivacaine has a longer duration because of its lipophilicity. It gets absorbed in the fat and produces longer duration of anesthesia. And this is the reason why old people have prolonged blockade. And this is how an epidural is given. They have loss of resistance sensation. They pierce the ligamentum flavum and deposit the drug outside the dura. And this how an epidural acts. The drug is deposited outside the dura. It diffuses through the dura due to the clefts in the dura and reaches the subarachnoid space. Other reasons are that it goes through the sacral foramina and the intervertebral and paravertebral phenomena and acts in the nerves. While it diffuses the dura, the more action through the dural slits or cuffs, where the dura is transiently absent, so the diffusion of the drug will be more there. And this is the posterior epidural space. The loss of resistance, the negative pressure in the epidural space is created by the presence of osmotic and hydrostatic forces of the Starling's law. This is the anterior epidural space. Sometimes if the catheter comes here through the posterior epidural space, it can transfer through the anterior epidural space, and if you aspirate the catheter, you can have a blood in the epidural catheter. And I think I have given an overview about what is a spinal anesthetic and how it is administered, what is the basic anatomy of the lumbar vertebra, what is the lamina, what are the structures based by the spinal needle, and what is the function of the dura, and what is the how to puncture the dura safely without causing much tear to the dura, and action of the local anesthetic and the hyperbaric solution and other isobaric solutions, and what is the order of blockade and differential blockade. Hopes it serves its purpose, and thank you for the opportunity.
Thank you. Thank you, Dr. Ganesan. Thanks for your good slides and good video and elaborate speech. And for the PGs, don't get panicked. This is the first session and there are some more sessions. And tomorrow there is a very good workshop organized by Professor Dr. Edward Johnson. At the end, definitely you will come to know what you are going to learn, that's all. So now we will shift on to the next.